Hello and welcome. Thanks for joining us. This is Aurora Health Alliance's virtual senior circle meeting. Hopefully that's the meeting you're supposed to be in. I know there have been a lot of Zoom crashers, so hopefully you're in the right place purposely here. My name is Jo Glaviano and I am the program coordinator with Aurora Health Alliance, and I also facilitate our senior circle meetings. So thanks for being here. So we're just going to go around. I'm going to call on you as I see you in my little boxes here. And if you could just say your name, what organization you represent, and your least favorite pie.
Least favorite.
So Bobby Joe, you're in my first upper left square. So you go first. You're on mute.
Too many windows open. My name is Bobby Morrell. I'm the communications coordinator for the Aurora Health Alliance. And my least favorite pie. I'm gonna probably ruffle some feathers, but I really don't like strawberry rhubarb.
Okay. It's okay. There's no judgment here. This is a safe zone. It's okay. It's fine. Dr. Betcher, Brienne, I see there. You're next.
Hi, everyone. My name is Bree Betcher. I am a neuropsychologist and researcher at the University of Colorado Alzheimer's and Cognition Center. And I'm going to be talking a little bit about what we do there today. My least favorite pie, also think probably controversial. I have not met a pie that I did not like, but generally apple is my least favorite.
Okay. Gotcha. I'm sorry to hear that, but it happens. Do you prefer Bree or Dr. Betcher or Brienne?
Bree's fine.
Okay, perfect. Thanks. Jeannie, you're up.
I'm up. I'm Jeannie Davis. I am vice chair of the Aurora Commission for Seniors. And is there something I dislike? Is that what I'm supposed to say?
Yeah, your least favorite pie.
Oh, my least
type of pie.
Pie. It's probably banana cream.
Oh.
Yeah, it just reminds me of stuff that my mom used to feed us years ago when we were kids, and I just don't like a banana cream pie.
Gotcha. That memory association.
Yes, that's right.
Thanks for being here.
You're
Dick,
welcome.
you're next.
Dick Doro with War Veterans Association of Colorado. Yeah, we also have Medicaid for Colorado. Those are the two companies that we operate. Least favorite pie, I'm going to have to agree. I really don't like cream pies.
Interesting. Another one for the cream pies. All right, thank you. Sandy?
I work with Dick, and we do the aid and attendance funding and Medicaid. I'm going to have to say hands down mincemeat.
Oh.
Yeah, I'm going to diss mincemeat.
Yeah. Meat doesn't belong in a pie. I was going to say that.
I don't think there's actual meat. I don't know why they
don't think
call
there
it
is either.
that. It's still objectionable.
Yeah. Thanks, Sandy. Shirley?
Hi, everybody. I'm Shirley Propey. I'm with Audio Information Network of Colorado. We provide access to podcasts and print for individuals that have any barrier to reading, so blind, visually impaired, or disabled, or physically not able to read. We serve all ages. We serve the whole state, and all three. So, I've never met a pie I didn't like, but when Sandy said mincemeat, it made me think I don't like kidney pie. That's nasty. So I'm going to go with kidney pie.
Okay. Oh boy. Mary Ellen, you're back.
Yes. Hi, I'm Mary Ellen Leeds. I'm with Arapahoe County Adult Protection, and I'm the prevention specialist. And I actually cannot think of any pie that I don't like at all. I would eat any pie.
Nice.
What?
Awesome. I think you should get a prize for that.
Me too. I'm all about
Pie in the
prizes.
face. Thanks, Mary Ellen.
Okay.
Sherry Dahan, you're next.
Okay, hi, I'm Sherry DeHaan. I work with Volunteers in Action, and I connect volunteers with low-income elderly and disabled. And during this time of COVID, when people are most vulnerable to get out, we have volunteers that are ready and waiting to assist. So if you have any clients or people, friends that you know about, let me know. I can connect them up with some awesome people to help care for them. And my least favorite pie is probably lemon, just too tart.
Okay, gotcha. Thanks, Sherry. Kimberly?
There we go. Hello. I'm Kimberly Diaz, owner of Care Matters Always. I'm a professional care navigator, registered nurse, so I do private duty nursing, private case management, and placement for seniors. I am celiac and I am zero carb, so I don't eat pie.
Gotcha. Not
My
even pie
favorite-
filling?
Not with the sweetness right now.
Yeah,
Orange,
right.
sorry.
that's okay. That's okay. Thanks for coming. And Courtney?
Yeah, my name is Courtney Carrick. I'm with the Arapahoe County Senior Resources Department. We do chore, transportation, homemaker services for seniors. I was scared to say, but it looks like Mandy also agrees. I am not a fan of pumpkin pie. I won't turn it down, but it's definitely not my favorite.
Gotcha. That's okay. That makes sense. It is kind of a strange pie when you think about it, you know? I mean,
Yeah, it just varies in flavor a lot.
Yeah.
It's gotta be
that's for sure.
the right one, I guess.
Thanks, Courtney. Karen?
Hi, everyone. I am a nurse with Tri-County Health Department. This is my first time attending, so I'm excited. And I don't love pumpkin pie. So
Okay.
but I will definitely give it a try every time it's in front of me at Thanksgiving.
Just keep on trying. I like the perseverance. Thanks for being here, Karen. And Katie?
Hello, this is also my first time on here. My name is Katie O'Brien. I work for Brookdale Tamarack Square, so we're in Southeast Denver. Independent senior living right now. We're still allowing seniors to move in. We're having them eat in our dining room, do small group activities. Families can come in and see them, as well as residents can go out and see their families. I know that we have new restrictions come Friday, but luckily we're not licensed here because we don't have assisted living. Those restrictions don't really apply to us. So we are just taking everything in strides and moving forward and really trying to make sure that our residents are still thriving given the circumstances. And yes, we have open availability. We start at $26.30 for a 1-bedroom apartment. Has all the meals included, housekeeping, transportation. Yeah, let us know if we can help anyone that you guys think of.
Great.
We're still
And
a
which-
safe place to live.
Yeah, and what's your least favorite pie flavor?
Oh yes, key lime pie probably for me. Not too much on lime.
Okay. Man, poor citrus. All right. Thanks, Katie, for being here. Alice?
Hi, I'm Alice Palmatier. I'm a Vista AmeriCorps volunteer at Benefits in Action. And I was going to say mincemeat, but now I have to say shoe fly pie.
I don't think I know what that is.
What is that?
Is it something sweet?
It's a Pennsylvania Dutch thing. I don't know, but it's nasty.
Especially flies in pies, probably.
Yeah.
Yeah. Thanks, Alice, for being here. And Rosalind? Is there Rosalind? Yeah. Hi, Rosalind.
Yes. Hello, everyone. And hi, Jeannie. Hi, I'm Rosalind Reese, Director of Diversity and Inclusion with the Alzheimer's Association in Colorado. And we provide education, counseling, and support to caregivers and family members caring for a loved one with any form of dementia. And we're doing all of that virtually with support groups and education classes. So if any of you have a need, reach out to me. I'll put my information in the chat. In terms of least favorite pie, I heard a theme of pumpkin pie. I do not like pumpkin pie.
All right, another
Thank you.
pumpkiner. Okay, thanks, Rosalind. Katrina Bengston.
Hello,
There you are.
I'm Dr. Bree Betcher at the CU Alzheimer's and Cognition Center at the Anschutz Medical Campus. I just help coordinate some of the research studies there and just work directly with her.
Awesome. And what's your least favorite type of pie?
Probably cherry pie. I've never been a big fan of that one.
Gotcha. Yeah, a new one. All right. Thanks, Katrina, for being here.
Of course.
And then Cindy, I think last but not least. See you snuck in there.
Hi there.
Hi.
Sorry, I can't have my video on. I don't have enough bandwidth here with my mom. I stay
That's
with
okay.
gardens. So what was the question?
Oh, so your name, what organization you're with, and your least favorite type of pie.
Okay, I'm Cindy Cook, and I am the owner of Aging at 5280. We are elder care managers and placement specialists. And my least favorite pie is mincemeat pie.
Okay, another mincemeat. All right, thanks, Cindy. Thanks for joining us.
Sure.
All right, well, thanks, everyone. We have the important issues taken care of, so on to more important issues. And I'm going to just share my screen very quickly, just to give you an overview. I hope you can see it. Oh, there we go. Does that work? Okay, great. And then how do I go? Here we go. So originally we had 3 speakers. Unfortunately, our speaker with the Center for Trauma and Resilience had to drop out. So I will put the link to their elder programs in the chat. They do have a lot of support programs for older adults who are victimized in whatever different ways that is. So I'll put that link in there, and then you can visit that page for their information. So we're going to start with Dick Duro, and I will stop sharing, Dick, and you can share your screen if you'd like.
I knew how to do that. Can you see me?
Yes.
Okay. So Dick Duro with War Veterans Association of Colorado and Medicaid for Colorado. So we do 2 things. We help people get VA aid and attendance benefits, and also long-term care Medicaid. So those are our 2 areas of expertise. I am a certified Medicaid planner. There's only, I believe, 3 in the state. So we kind of look at each case to see where we can help people. Our cases come to us generally from referrals from placement agencies or from facilities. And we're almost always dealing with people who are in crisis like all the rest of us. And so we try to help those along and make the right decision, help them make the right decision, and see if our services are appropriate for them. VA offers benefits for people that serve during a period of conflict. They offer also benefits for people who were hurt or injured in the military. We do some of the work with people who were hurt or injured in the military, and a majority of our work is for people who could qualify for what are called pension benefits. Those are need-based benefits, and they qualify for reason of service, disability, income, and assets. All 4 things have to be true in order to get the money. But if someone served during a period of conflict and has a need, the VA defines need as someone who has below $129,000 in assets, and their income is less than their medical cost of care. Whatever that medical cost of care is anticipated for the next year is the way they determine eligibility. They project for the next 12 months someone's income, and they project for the next 12 months someone's cost of care. And they compare the two, and if you happen to have more cost of care projected than income projected, then you can get the benefit. And the benefit is, let's see, they just changed the rates. It's $19.36 for a veteran and $12.44 for a surviving spouse, $22.95 for a married couple, and $15.20 for a spouse of a veteran, if the spouse needs help and the veteran does not. So they're varying amounts of money. And if you qualify for it, you generally get the money forever. Unless something changes, you win the lottery, and very few people who are in long-term care win the lottery. So they or have an inheritance. Sometimes it does happen, but very rare. So pretty much a permanent benefit, tax-free, a good deal of paperwork on the front end. I just did two this morning. They were 42 and 47 pages long, counting all the documentation and signature pages and forms, and hundreds of entries in each one. Some of them pretty routine, some mundane, some are specific to their particular case. So we've been doing this 10 years, and I have personally done over 1,200 applications. So I do have a good deal of expertise in that area, and we have done quite a few Medicaid cases, quite to success. Medicaid is a little more straightforward than VA is, but it's still challenging because Medicaid has the right to look back 5 years at any of your financial transactions that have happened. And if they suspect something is awry, they will ask for 5 years worth of documentation. So it's my advice to anyone who's applying for Medicaid is tell the truth. Of course, that would be my advice to anyone about anything, is tell the truth. But that certainly is something you need to follow. So we can help people with benefits. And depending upon their situation, we always look to VA first if that would make the difference between what their income is and their cost of care. If they're in assisted living or independent living under certain circumstances, we can get money for them. But sometimes Medicaid doesn't provide enough money. Someone who's going into skilled nursing at $8,000 or $10,000 a month, a benefit of a couple of thousand is not going to be helpful, not going to solve their problem. It might help, and in some cases we do both, but we look to each individual case to see what situation might help them the most, or if we can help them at all. I can tell you that we don't take a case that we're not sure we're going to get the benefit for. So we walk away from a good deal of cases. We have near 100% success rate because of that attitude that we really don't want to just take people's money. We're not lawyers, so we don't take money for time. We look at a case, evaluate it, say, how can we help them? If we can, then we'll take it. But if we can't, we typically do not take those cases. So success rate very high, satisfaction rate on our part very high, because we do help a lot of people, and we're just in the same business everyone else is. We're helping people in tragic circumstances, in crisis, in need. Certainly we try to help see the emotional side of the case and provide that as much as we can. We kind of stand in between the people that care and the people that don't care. If you have experience with bureaucracy in the federal level or the state level, you oftentimes come away with a feeling that no one there cares about you. It doesn't matter how much you did. If you didn't do it all right, they're not going to do anything for you or go out of their way. But that's not our attitude. We always say to people, look, I see your situation. I care about it. I'll do what I can to help you. But I'm sorry to say that these people don't care, and that's what we're here for, is to stand in between and navigate those shoals, if you will. I don't have a lot. We have short time, so I thought I'd just open it up for general questions and try to answer specific questions. Maybe that would answer questions for anyone else about what we do. Anyone?
I have a question. This is Jeannie.
Hi, Jeannie.
Hi, how are you, Dick?
I'm well, thank you.
Good. I don't know how to raise my hand on this thing. Otherwise, I would have been more courteous and done that, but I don't see anything down here that says raise your hand.
You're fine. Love to hear your question.
My question is, I moved my parents to Denver 4 years ago. And at that time, they were not Medicaid eligible. They were in an assisted living community. This 5-year stipulation, and sometimes 7-year stipulation, if you're not planning to need that kind of assistance, you don't know not to sell your house or give your daughter $100,000 or, some of the other things that disqualify you. Why is there such a stipulation on that?
Well, the program, you're talking about the state Medicaid.
The state Medicaid, yes. Turns out they did end up in a skilled nursing facility. I did have to sell their house in Pittsburgh, and I sought legal aid assistance in working through that process. I since have lost both of them to COVID 2 days apart.
So your general question is, I sense your frustration about it. Well, the Medicaid program is designed to help people in need, and they define what need is. So if you've transferred anything of value in the last 5 years without consideration, in other words, it's okay to sell your house as long as you got the fair value for it. If you give something away, then the only way you'd remedy that gift, there are 2 ways. One is to give it back. If I gave you a horse, that you give me that same horse back. Mm-hmm. If I gave you $5,000, you give me $5,000, not $4,998 back. So return of the exact amount will remedy that. And then there are ways to speed up the process. I think it's beyond the scope of this presentation to tell you how, but yes, there are ways to speed up the process of qualification for Medicaid. Mm-hmm. If you talk to a certified Medicaid planner, a lawyer that's a state planning attorney that has experience, not just because they're an attorney, I wouldn't recommend going to one, but if they're an estate planning attorney, then they're going to be familiar with Medicaid process. It's different, and there are ways to qualify without giving up everything. And we do that all the time. Mm-hmm. So I think private consultation we welcome.
Thank you.
I have a question. And first of all, Jeannie, I'm sorry to hear about your parents.
Thank you.
And your loss.
Me too.
Yeah. My question is, so to qualify for aid and attendance benefits, you have to be a veteran who is served within whatever the specifics, time and places and that, plus an income piece, plus your care that you need.
For qualification. Service during a period of conflict.
Okay.
Anywhere in the world. So there's no place associated with it, just time.
Okay.
So right now we're seeing mostly people from Korea and Vietnam. We do still see some from World War II. There's still, there's almost, I think there's 50,000 people, 50,000 veterans still living from World War II. Wow. They're dying at a rapid rate. So World War II, Korea, Vietnam, those are the ones that the most prominent now. And then your assets have to be below 129,000, which is basically the same asset level as a couple could have and qualify for Medicaid. So Medicaid has on the income side, they have a $2,000 asset level for an individual, but 129,000, it's 128,640, but 129,000 is what we use to qualify for a spousal. If you have a community spouse and an institutionalized spouse, then your asset level is 129. But for VA, it's the service during a period of conflict, disability. A doctor essentially has to say you need help. It's more detailed than that, but
Sure.
Just keep that in mind. Activities of daily living. But if someone needs help, then we can generally get them qualified, because if I look at a doctor and I say, do you want this individual to be in a protected environment? And they say yes, they're going to be cooperative about filling out forms. It all depends upon how the doctor perceives that relationship with the client. Then in terms of income, there really is no income limit. It's more that their income is less than their medical cost of care. Medical cost of care considered by the VA is any sort of institutionalized care, such as assisted living or long-term care. And then, so there are finite differences between that and Medicaid. Medicaid, by the way, the income limit that they post is really only the limit up to where you do not need an income trust. Anything beyond that income amount for Medicaid, you merely need to fill out another form. So there virtually is no income limit for Medicaid. That's probably the most misunderstood part about long-term care Medicaid in Colorado. Most people think there's some sort of income limit, and the state publishes one, but there's to exceed that income limit, you just fill out a form. And like I say, beyond the scope of the conversation about how that works, but essentially it's a form and a process that lets you exceed what's published as the income limit for Medicaid. I hope I answered your question about VA. I kind of got off course here with Medicaid, but.
No, you did. Thank you. And I saw Sandy, you put in the periods of conflict in the chat. So thanks for that. Any other questions?
I have a question. How much do you charge for helping people apply for benefits?
It depends upon the case, but for VA, it's generally $990. But that covers everything. Again, we don't take money from anybody that we're not sure we're going to get the benefit for. And oftentimes we'll file a month early before. If you want to do it on your own, you're probably going to take a couple of months, and if we can get involved early enough, we can get another month or two benefit for you. So we can save you that money, generally speaking, on almost all cases, because we're getting in early, we're getting the thing done, and we're getting money coming to them. We can get it both sooner, and we can get the benefit backdated also.
We also offer a free initial consultation, so we can do an eligibility review, look at their circumstances. That's part of how we evaluate if they have a case that can move forward with the VA. But it also just lets them know they may not be ready to move forward now, but they will know their likelihood of qualifying for either of the two benefits.
Yeah, we often see, one came to Sandy the other day that was a year old. Someone had not qualified. We met with them and they came back when they were qualified. So it's a lot. It makes sense to speak to us because we see cases that come in, and a lot of times where people say, I wish I'd seen you 6 months ago or a year ago. I could have been eligible for this, or for either VA or Medicaid. So touching base with us is certainly worth the time, I think. And I'm happy to get on the phone with anybody who, especially those people that are placement individuals. We can we can help them by establishing third-party credibility with their potential client, or we can, because you bring on an expert in a field, why it does lend credibility to yourself. So we're real high on that. Calling us if you have the client in the office and saying, "Hey, Dick, you got a couple of minutes? Can you spend time on this one with us and review the set of circumstances to see if we're qualified?"
Great. Thank you. Any other questions? And Dick or Sandy, if you wouldn't mind putting in the chat just the contact info, so that way people can take it away, and we'll also include that in our follow-up email that we do. Any other last questions for Dick about in attendance? Or all right. Well, thank you very much, Dick. We really appreciate it. Appreciate your time and the information.
Thank you for spending time with me. I appreciate it.
Yeah, absolutely. All right, Bree, you are up. And I think you should be able to share your screen, hopefully.
Right.
Great.
Yes, hopefully everyone can see that. Let's get it going. So I did prepare a full presentation for everyone. It's hard to come from an academic medical center and not put together a full presentation. I apologize in advance if this is not what you intended, so feel free to interject. As I mentioned at the beginning, I am a neuropsychologist and a researcher at the University of Colorado Alzheimer's and Cognition Center. So that's at the Anschutz Medical Campus. And so the vast majority of my work has really focused there on healthy aging and understanding the cascade of events that happen in the body and in the brain that actually precede the onset of Alzheimer's disease. And I think over the past decade, and even more recently, there's been such a shift in our understanding of Alzheimer's disease and related disorders that has pushed the research community to rethink common ideas of what defines healthy and normal aging. So the goal of this presentation is really just to outline very briefly how our thinking has changed in terms of Alzheimer's disease, to introduce you to the CU Alzheimer's and Cognition Center, and then just to briefly review some research studies that we have going on and how that's evolved with the pandemic as well. Let's see here. Okay, so I think we could probably all agree that Alzheimer's disease has really significantly impacted our communities and most families in some way or another, whether it's knowing someone or caring for someone who has experienced this condition, or even for folks who feel like they're having changes in memory themselves. And so while we previously thought that there were many aspects of Alzheimer's disease risk that were set in stone, we are now learning that there are quite a few factors that likely mitigate or lessen the risk for Alzheimer's disease. And there was this really recent report that just came out from Lancet, which is a very well-respected journal in our field, on dementia prevention. And it summarized a lot of this literature in terms of risk and prevention. And quite strikingly, what they showed in that article was that modifying certain risk factors might prevent or delay up to 40% of dementias, which is a really striking number. And again, I think it speaks to this idea of how we're evolving our concepts of neurological conditions and progressive conditions, and pushing us to think a little bit more about a lifespan perspective or a life course perspective, and what are the things that are happening over time that might put us on a path of Alzheimer's disease. Not to say that it's causal, but things that are contributing. I think the bottom line from this article and from what we are learning more and more is that what we do in our 30s, 40s, 50s, 60s might have meaningful impact on the likelihood and the timing of symptoms that are shown with Alzheimer's disease. And I think collectively as a researcher, there are very significant implications to this in terms of making sure we better understand what are these factors, what is the right time window that we could intervene and help prevent or delay Alzheimer's disease. And this is a little bit of a technical slide, but just before I introduce more about the Alzheimer's Center, I wanted to give you just one more window into how we think about Alzheimer's disease from a biological and clinical perspective and how that's changed. You know, we really see this diversity, I would say, of aging narratives in late life, to the extent that even more so than in early or midlife, aging is really defined by heterogeneous courses. So some individuals develop Alzheimer's disease, others develop other dementias that are not Alzheimer's disease, and then other individuals age without significant changes in their thinking. And the diversity of those experiences are likely due to a combination of different things that emerge in late life. But I think it also reflects different responses to the disease itself. We know that Alzheimer's disease is typically characterized by amyloid and tau proteins. So those are two major proteins, not the full picture, but those are sort of hallmarks of Alzheimer's disease. However, one of the more seminal studies and ones that are continually debated to this day is that having the brain pathology of Alzheimer's disease does not mean that everyone will manifest it in the same way or at the same time. And so, in other words, what we see under the microscope does not always map on to what we see with the person in front of us. So some people who have Alzheimer's disease in the brain will present with symptoms, memory symptoms, and be diagnosed with Alzheimer's. And other people with Alzheimer's disease in the brain won't show symptoms at a specific time. They may show symptoms later, but they can actually have that disease in the brain and not show any symptoms, so be asymptomatic. And it suggests to me and to a lot of the Alzheimer's community that at least a portion of Alzheimer's disease is impacted by different risk and protective factors that influence when and how it might be expressed. And so based on that, a lot of research focuses not only on people with Alzheimer's disease, but in people without it. So looking at healthy aging from a more of a life course perspective and getting a sense of what precedes symptoms and what might be protective over time. So just to introduce you, many of you probably know the CU Alzheimer's and Cognition Center. It was previously referred to as the Rocky Mountain Alzheimer's Disease Center. They recently changed the name. But the mission of the center is really to discover effective early diagnostics, so being able to diagnose earlier, which helps get people into an appropriate clinical trial, to focus on preventions, treatments, and ultimately curing Alzheimer's disease and degenerative disorders. We have a really big interdisciplinary team. So we have clinical researchers, meaning researchers that study aging adults. We have laboratory researchers, so researchers that work with animal models to better understand Alzheimer's disease. And we also have clinicians, so people who primarily work in the clinic with people who are affected by these disorders, as well as a wonderful, huge staff that helps run all of our studies. We offer clinical care, so there's a memory disorders clinic that's at the UC Health Central Park Medical Center where we see patients. We have clinical trials, so interventional studies that involve drug therapeutics. We also have observational studies, and I oversee many of the observational studies in the center. And those are studies where we bring people in and learn from them, track people, follow them over time, and learn what either puts them at risk or helps protect them. And then again, we have the laboratory research as well. And this is just to give you a brief summary of all those different components. So it's our memory disorders clinic with neurologists. I'm the neuropsychologist, the one there. We have a fellow, nurse. We're seeing over 2,500 patients per year. And then we have quite a few of these aging research studies. So we have ongoing research studies with people who have symptoms of Alzheimer's disease or atypical Alzheimer's disease. And then we have quite a few studies going on that I'll briefly touch on that involve healthy aging or aging without significant memory problems. Just to give you a brief window into some of the healthy aging studies, because again, I think this is often not, people don't often think about this necessarily when you think about an Alzheimer's center, but we have a growing, large, healthy aging research program. And in this, we look at a variety of different things. We look at the immune system, which is very relevant right now in terms of the pandemic. We look at things like risk factors like concussions. We look at sleep and how that relates to outcomes, and also changes in thinking, like word finding difficulties. And we really try to take this holistic, comprehensive view of all the possible changes that are occurring in the body and in the brain that may precede or protect against Alzheimer's disease symptoms. And just quickly, I wanted to highlight 2 different studies that we have going on. This is just a microcosm of the broader piece that we're looking at, but one of the studies is looking at concussion and brain aging over time. So we know that concussion is a risk factor for neurological problems in late life. I'm sure a lot of you hear about this on the news in terms of the football players and how that relates. However, most of that research not only has been done with very specific populations, but it's mostly been done with younger people and following them over time. We don't know a lot about what happens if you are over the age of 60 and you have a concussion later in life and what that means. We know that outcomes tend to be not as good as as with younger adults. The hospital times tend to be longer, but we don't have a great sense of how much of a risk that is and why for changes in late life. So we are currently doing one of the few studies right now looking at concussion in older adults. The study is called MTAB, so Inflammation, Mild Traumatic Brain Injury, and Alzheimer's Disease Biomarkers. It involves 2 visits, so just wanted to give you an idea about that one. We have another one that I mentioned on the immune system and aging. And so most of my work and our director, Hunt Potter, a lot of our work really focuses on changes in the immune system and how that impacts aging. So we had this study funded prior to COVID. So this has been something of interest for quite some time. We know that your immune system changes quite a bit as you get older, and that includes your response to infections and how well you can resolve an infection. And so there are many changes in the body and in the brain with respect to the immune system that we know are impacting Alzheimer's disease, but it's still really unclear how these different systems interact. And also, is it possible that we could harness good parts of your immune system, so the parts that should be fighting illness, and dampen down aspects of it that are becoming dysregulated? And so prior to COVID, we had this study funded, and it's looking at immunity, infections, and aging. Again, bringing in people who don't have symptoms of Alzheimer's disease and following them over a 2-year period. This is for people who are 60 and older. And again, to better understand how any changes in the immune system and any infections that are coming up impact someone's course. Related to that, with COVID, so very, very relevant to the immune system and aging. You could probably have a whole nother discussion just in terms of COVID and neurological impacts of that over time. I want to just briefly cover a few things. So first of all, the National Institute on Aging gave us a small grant to add on to that study I just mentioned, the LEA study. And we will actually be doing antibody testing in our study over time. So looking at antibodies to COVID-19 in the blood, both at baseline and the follow-up, to see if that impacts in any way someone's thinking or memory, or if there's any protective factor there. Participants in the study all will receive the results of the antibody test for this one. And so that's a major aspect of change. We're also bringing in people who have previously had COVID and are doing better at this point to better understand those trajectories. It's an evolving time. And so we have a meeting every single week about COVID and precautions. Some of that may be changing over the next few days as well. We're really just trying to keep in mind that while Alzheimer's disease and these important issues are not going away, we want to make sure that we're being as safe as possible. And so currently we follow all the university policies and then some. So we pre-screen all of our participants for comorbid, so multiple medical conditions. We're using HEPA filters in our rooms. We have big plexiglass dividers. We've also moved portions of our research evaluations to video-based calls. And I think part of what is important that we really need to focus on is what are the long-term impacts of COVID-19, which we don't know at this point yet. And so this is a busy slide. I just want to highlight that there is evidence that there could be there are neurological symptoms that are associated with COVID-19. I think there's a lot of remaining questions as to what will happen over time, and will this resolve, and will there be differences in people who are in different age brackets or have different risk factors in terms of whether or not it's putting people at risk for neurological problems chronically. Again, something that we aren't sure yet and are trying to better understand. And this goes along with a lot of literature that we were interested in before COVID, but has now become even more salient, which is, does the increased likelihood of having neuroinflammation or brain inflammation put someone at even greater risk for dementia later, or could it impact that in some way? And so that's something that we are continuing to look at. It's not just me, it's our whole center is focused on this as well to better understand it. And I just wanted to end, hopefully I did not go over the time, just some of the contacts. Again, we have really wonderful research coordinators. They can always tell you when you get on the phone whether or not we're currently seeing participants or if things are on hold. Some of that will depend on the person's age and health history. But we always have a waiting list in case people are interested in joining later. So I put the Memory Disorders Clinic contact there in case someone is interested in having an evaluation, so are having active memory problems or other thinking difficulties. And then the contact for the research program. And so the phone number, the email, and also our website, which is cumemoryresearch.org, in case people are interested. Just to show you our huge team at the Alzheimer's Center who are always actively working on these topics. Okay, thank you. I really appreciate being able to introduce you to the center if you hadn't worked with them before. And does anybody have any questions?
Thanks, Bree. I mean, I have a couple questions. My first question is, what is adiposity? Adiposity, ADIPOSITY. What is that?
That is some more jargon, scientific jargon from weight. And so having having higher weight, particularly around your midsection. And so, you know, I think previously we looked a lot at body mass index, but we've learned more and more that people who are carrying weight around their midsection has more effect on their heart, which can impact their brain as well. So just a scientific term for that.
Thank you.
Sure.
I mean, I think what the work you're doing is fascinating, especially the idea of neuroinflammation and how COVID, so the thought is, could COVID eventually cause some sort of cognitive issue in the future? So if I'm in my 40s and if I get it, who knows what the effect would be. Are you able to, how long are you able to continue the study, the COVID study that you're doing? How long will that go? I mean, are you able to do it kind of years and years, or is it just kind of a couple years type of thing?
We started the study last year before COVID, and we had the focus on infections, but then with this, with everything that's changed, that's amplified. So our study was funded last year for 5 years. And we will likely get an additional year on it because of everything going on. People who enroll in the study, we will see them at their initial point and then 2 years later, and then we contact them every 6 months to get a sense of have they been exposed to any infection. So have they had respiratory infections that are not COVID? So we're looking at all of that together. So pre-COVID, there was interesting and worrisome data that had come out suggesting that if someone, this was not in healthy people, it was people who had Alzheimer's disease symptoms, that if they had higher levels of inflammation in the body and then they got a respiratory infection, that they were more likely to have worse memory changes over time than those who did not get that respiratory infection. And so that was with people with Alzheimer's disease. And so there's been this concern for a while that as we get older, the changes in our immune system kind of prime us in some way to have an exaggerated response. And so we're trying to better understand, what does this mean for something like COVID, where they've already started to see some neurological impacts? And can we figure out who is at most risk for developing symptoms long term?
It's fascinating. It really is interesting. Thanks for the work you do.
Oh, of course. It's a pleasure.
Yeah.
And I hope folks also know that it often comes across, I think, as very negative and worrisome, but we're also actively always trying to look at protective factors as well, because that will tell us, to me, just as much as learning about the risk factors, because that's something that we can harness and learn from and hopefully capitalize on, seeing people who have protective factors and what we can do about that too.
I do have a question. Can you address the issue of the degree of COVID loading that someone might experience in relationship to the degree of the immunity that that person has? For instance, if someone has a low degree of COVID exposure and a high immune resistance versus someone who has a high COVID loading, experiences that and has a low immune response.
Yeah, so a couple of things with that. So prior to COVID, or at the onset of COVID, this was a novel coronavirus. So there are numerous coronavirus viruses out there, but this was a novel one, meaning that we did not have an immune response or high immune load towards this virus. And so nobody at the beginning of it had that high immune load because it was completely novel. And so I think the question over time will be, for folks who have had smaller exposure levels over time, are they able to build up some level of antibody response so that they have a higher load at that point? And if they have a greater exposure, will they be able to fight it off versus people who have not developed that over time? But I think that's very different than in the beginning when we just did not have any immune response yet that was appropriate because it was so novel. I think the other question will be, I'm sure many of you have heard about the two vaccines, one by Pfizer that looks like it's about 90%, and the other one that's about 95%, which is very exciting. How that's going to impact people as well, and if there will be a differential effect if people have Alzheimer's disease in the brain. I think there's just a lot of that that's not known, which I realize is a very unsatisfying response to your question. But I think a lot of that is truly unknown. You know, I think just a couple of days ago it came out that it's possible that our immune response and antibody response may actually last much longer than we initially thought to the coronavirus. Again, each week there's new information coming out all the time, and we probably will not have a full picture of it for some time now. I can tell you just in general that your dose, so the amount of exposure, does seem to impact your response quite a bit. So you try to limit your exposure. So high exposure would be a high dose response, tends to be worse. But apart from that, it's such an evolving field. I'm on I was on this international immune call, which I'm sure sounds very, very exciting, last week, where we were talking about COVID research, and just every week things are changing. It's very challenging to keep up with the evolving science, which is good. It's nice.
One follow-up question: is there any apprehension about? If we have seniors who have Alzheimer's, who are in long-term care facilities and who need to be protected, are the apprehension about giving inoculations to these people? Are we going to? Do you think we'll just go forward and inoculate as many vulnerable people as possible so we can get back to normal? We're all hoping for some normalcy here.
Of course. Well, I should clarify, I'm a PhD, not an MD, but I can tell you that, at CU Anschutz, we've been having a lot of these discussions in terms of the vaccine and the likelihood that there would be some sort of stratification. My understanding, which may change, is that frontline healthcare workers would probably be initially prioritized. There is discussion around people who are most vulnerable, who are in nursing home settings, and others could also at that point be prioritized, but we're not sure yet exactly what that plan will be. But certainly the vulnerability, and both in terms of health-related diseases as well as age, will likely be taken into account too.
Thank you.
Mm-hmm.
Hi, Dr. Betcher. Thank you for all you do. Certainly, we appreciate the partnership we have with you all from the Alzheimer's Association. I wondered, and you may have said this in your presentation, how is inflammation actually measured or determined in the body?
Mm-hmm. So inflammation is it's a broad term that has to do with your body's systemic response to something. Usually it's what we call a pathogen or something from outside the body, but it can also be from inside the body. Typically what is done to measure body inflammation is to look at markers in the blood. And so taking a blood sample and looking at protein levels of specific inflammatory markers and seeing if they are higher or lower. That's the most common way. That is a little bit different than looking at inflammation in the brain. There is a blood-brain barrier. So what's going on in the body isn't 100% shared with the brain and vice versa because of this barrier. We know that barrier gets a little bit leakier over time. And so there is some sharing of it, which is why people are becoming more and more interested in a blood test for Alzheimer's disease, because it seems like there is some things that are shed into the blood. Currently, measuring inflammation in the brain is done with spinal fluid, and that's the most direct way because the brain is sort of bathed in that fluid, unlike blood. And so it's usually, in either case, looking at what we call a biofluid approach.
Oh, sorry, thanks. So what is the test called for to measure it in the body? Is that a different test name other than the spinal fluid test?
Do you mean if you go into a clinic and they do that?
Yeah.
Usually, so in clinical settings, oftentimes if it's not suspected that you have an autoimmune disorder or some other major immune disorder, oftentimes people will run a general blood panel, and as part of that, they will get something like C-reactive protein or CRP, which is a proxy for inflammation. We in research, we look at a lot more than that. We usually look at 30 or more markers. Just because that one that I mentioned is not necessarily very specific.
Thank you.
All right, and I think our wonderful researcher coordinator, Katrina, just reiterated our contact information in the chat box. You know, we're very open to working with the community. I certainly think it's my responsibility and my pleasure and joy to be able to give talks and also participate in town hall meetings or discussions. It doesn't have to be a talk. And so certainly let me know if you're ever interested in having dialogues around these topics or how we can be helpful.
Thank you so much. And are you still looking for individuals to include in the research that you're doing? And are you including diverse populations and outreaching to them? How is that working?
Yes, so we are definitely still actively looking, and we'll, for the studies I mentioned, we will be for the next few years. And again, people can be on a wait list if they're interested and feel more comfortable waiting for a little while. And so we are reaching out to a wide variety of communities, very open to suggestions around that as well. The CU Alzheimer's and Cognition Center, we also are working with our African American Council to discuss outreach to African American communities. And so we are very open to ideas around outreach because we know also that Alzheimer's disease differentially impacts people from different groups. And we want to make sure that when we do have a treatment available, that we have the right treatment and a complete picture of how that will look.
Awesome. Thank you so much. Thanks for the time and information and the work you do.
Of course. Thank you all for having me. I really appreciate it. Nice to meet all of you. It's so exciting to see so many people involved in the aging space. So nice to meet everybody.
Yeah, thank you. Okay, so now we have a little bit of time left if anyone has any announcements they'd like to make. Thanks, Roslyn. Any announcements or resources or anything you'd like to mention? Go ahead. And Sandy, did you have your hand up? No.
That was applause. I did a little.
Oh, okay. Okay. Yes. Any events coming up, virtual events that you know about? I do know that there is an event addressing workplace age discrimination in Colorado is coming up on Friday. It is a webinar. I believe it's through the Action Network. And so I'll put the link in there if anyone's interested in joining that. I believe it's at 10 o'clock in the morning. So there is that coming up. Anything else? Anyone? I'll go again then. Arapahoe County Council on Aging. Our next meeting is actually on Monday, the 23rd. And it is virtual. It is using Zoom. It is at 1 o'clock, I believe. So if you're interested in joining us there, I'll put some of that info in the chat. If you do want to just put any information you have in the chat too, we can do that. We try and save it all and send it out in our follow-up email. And then Bree, are you okay with sharing, allowing us to share your PowerPoint? Is that something we could share in our follow-up or no?
Yes. Yes.
Okay.
But yes, I think that we made sure not to have any copyrighted material.
Okay. Okay, great. Perfect. Thank you. All right. If there's nothing else or any announcements, anything, hope you all just have a safe holiday. Please stay safe and, do what you have to do. This virus is getting closer as we speak. So I know we all maybe know someone. I now know people that have it. So please stay safe. And like I said, we will continue Senior Circle virtually probably through most of next year, but we'll kind of keep you all updated. So thanks everyone. Thanks for joining us. Thank you to Dick and to Bree for your information. And you all just have a happy holiday.